Hi everybody, today we're going to talk about the concept of perfusion and focus specifically on the exemplar brain attack. The objectives of this session, we're going to describe the pathoetiology, manifestations, direct and indirect causes of stroke. We're going to look at risk factors and prevention methods associated with stroke. We're going to illustrate the nursing process so we can provide culturally competent care for individuals. We're going to look at some priority nursing diagnoses appropriate for these individuals. Also summarize therapies used by interdisciplinary teams in the collaborative care of clients. And we are going to use evidence-based care for individuals, and we're going to do that through the nursing process from assessment to evaluation. So stroke is also known as a cerebrovascular accident or brain attack being the preferred terminology now. This is a neurological deficit that results from a sudden decrease in blood flow to a localized area of the brain. Now they can be ischemic or hemorrhagic, and within ischemic they can be caused by an embolus or even stenosis. Neurological deficits could vary, and those are always, and I'm going to bring this to your attention and say it a lot, according to the area of the brain affected. It's the fourth leading cause of death and disability in North America. Survivors of strokes or brain attacks may have some degree of impairment, and it could be from a little to a lot. And we're going to talk a little bit about that later. A really important note is that the highest incidence is in individuals that are age 65 or greater, and we want to know why, right? So we're going to talk about that. They are also more frequent in men than women. However, an exception is in women, they're greater during pregnancy and the first 6 weeks postpartum. So we'd love you to sit there and pause for a minute and think about why in women, why during pregnancy, and why the first weeks postpartum. So we do want to look at patho and etiology, kind of wrap our brains around what all this means. The brain accounts for 20% of oxygen consumption. The body also has this thing in its receptors and everything, but it auto-regulates. So the body is going to try to maintain homeostasis, and it can't do that if the systolic blood pressure is less than 50 or greater than 160 millimeters of mercury. When you think about just in a patho sense, the blood flow and oxygenation to cerebral neurons is essentially decreased. This can happen at a cellular level within about 4 or 5 minutes. As that cellular metabolism ceases, cell walls can swell. This can cause cerebral blood vessel walls also to swell. Now, when we're thinking about the connection with blood pressure, we want to think about hypertension, and this will cause an increased cerebral blood flow. However, as we know with hypertension, this can cause overdistension of the cerebral vessels. We can also have decreased stop blood flow. Ultimately, again, if you have a problem with perfusion, usually you're going to have a connected and a related concept and a problem with decreased oxygenation, all of that being very bad. Also glucose, glycogen, adenosine triphosphate, those start to get depleted. You can have potassium sodium pump failures. You may have vasospasms and increased blood viscosity, and that means the blood's getting thicker. And then when the blood gets thicker, what are we more prone to? I hope your brain is probably thinking clots, and that could lead us to a stroke. So when we're thinking about that cellular metabolism that's decreasing or ceasing, cells swelling, blood vessel walls swelling, and we're thinking about central cores of cells, they could be dead or dying. And sometimes that you can have an area where there's a band of cells around a dead portion of cells, but those are minimally perfused cells. The survival of these cells depends on, and this is key, timely return of adequate circulation. So when you are thinking brain attack, and I want you to think time is neurons, okay, because that's especially what we're talking about. Time is important here. So the quicker we can return circulation and provide perfusion, the better off a client may be with being able to restore function ultimately. Some other things it can depend on are toxic products released by dying cells, um, the death of cells or area of ischemia or something of that nature can cause cerebral edema, and the degree of that can also have an effect. The alterations in blood flow locally, those are always going to play in. Um, Typically, things will be characterized by a gradual or manifestations, not things, characterized, they can be gradual or rapid onset of neurological deficits. And we're going to talk more about that when we get to manifestations because it's going to depend on the type of stroke. And there's a couple of different types. What you tend to see, though, is that it's usually also based on the manifestations, the affected area of the brain. And also you're going to see a contralateral deficit. So contralateral will be if there's a stroke in the left side of the hemisphere of the brain somewhere, you're probably going to see deficits that are manifesting on the right side of the body. And that's really important too. So like I said, there's different types of strokes and we're going to talk about each one individually. Ischemic is one of the first ones, and this is due to a blockage and or stenosis of the cerebral artery. So this could be from blood clots or stenosis caused by plaque buildup. Now there's a couple of different types that we're going to talk about, and we're going to talk about TIAs, thrombotic, and embolotic or embolic. So one of the first ischemic types that we're going to talk about is called a transient ischemic attack, or a TIA. A lot of times you're going to hear these called as mini strokes. Okay, so this is again decreased perfusion, and it causes deficits lasting less than 24 hours. Okay, so these manifestations may be present for minutes or hours, and the time, this could be like a warning. This, when we say a mini stroke, we can say, oh, well, this may be a warning to a predictor of something bigger, a bigger stroke. And again, the time between a TIA and a stroke, it can vary. So someone may have what's called a mini stroke or a TIA, and then, very shortly after have a full-on stroke. There's a couple of causes, and this could be due to inflammatory artery disease. Sickle cell is another thing, atherosclerotic changes in the blood vessels, thrombosis, or emboli. Again, neurologic manifestations depend on the location of the brain and where it's occurred and the size. Please know they will have a sudden onset. Manifestations tend to disappear from a few minutes to hours, up to 24 hours. And what you're actually going to see, we're going to talk more about when we get to the manifestation section. Another type of ischemic stroke is going to be thrombotic, and this is where there's an occlusion of a large cerebral vessel by a thrombus. And this tends to occur in older and sleeping individuals. So here's where we need to pause, because this is a great opportunity to ask why. Why older? Why sleeping? So think about this. Does your blood pressure go down when you sleep? So like the more active you are, sometimes your blood pressure can go up, but as you're resting, it will tend to go down. So that means there's a little bit less perfusion going on, and there's less pressure to push blood through narrowed arteries. Now, when we think about our aging population, older population, well, our blood vessels don't work the way that they used to do. So maybe they can't constrict and dilate like they used to. So then we have a tendency, maybe blood can not perfuse and maybe pool, and then thrombus or clots can develop. So let's go back to a thrombi related to plaque possibly. So basically what you're going to have in that situation are platelets that adhere to the vessel wall, and that happens a lot to our older population and even some of us younger ones. This is going to potentiate an initiation of a clotting sequence. Okay, so then you have those clots form, and that's how this thrombus forms. Now, that's not the end of the story, but we're going to stop there just with thrombotic. Okay, please remember that manifestations, again, vary according to the size and location of the affected area in the brain. That is making all the difference in the world. Okay, this type of brain attack will have a rapid onset, but slow progression. So here's how it works. Remember, TIAs, they had a little bit of a rapid onset, but the manifestations will tend to disappear or minimize. This is different. This is going to have a slower progression, so it's going to begin with one of those mini strokes possibly, and then it's going to worsen or progress over 1 to 2, maybe 3 days. Okay, so you need to be really astute when you're assessing your patients that come into the hospital. If we're ruling out a stroke and we're looking at a TIA versus a thrombotic stroke, what you may see is they tend to get worse over a couple of days. So frequent assessments are a must. All right, so still on ischemic, but let's talk about those emboli, or embolic or embolotic types of attacks, brain attacks. This is where, now we just talked about that clot. So what happens with the embolus? It moves. So now it gets lodged, and it's going to get lodged probably in a narrow vessel. You know, those clots, they can clump together, travel through, and, you know, they just get stuck somewhere. And if something gets stuck in a vessel that is providing blood and oxygenation and perfusion, you know, then we have a severe damage, and we can cause cells to die if there's not enough oxygen. Typically, you're going to see this in younger clients. So here's something different, and usually during awake and active times. I'm sorry, that was a typo there. It should not say aware, but this can happen in younger, while we're awake, and during active times. So I want you to think about why that could happen. So let's look at the opposite of what we just talked about. When you're awake, blood pressure is moving. When you're younger, those vessels are dilating and contracting and perfusing and oxygenating. So if there was this clot that turns into an embolus and moves, all the activity and the really great body systems and perfusion will cause it to move. And that is why during awake and active times, possibly younger individuals can form this embolus and have an embolic stroke. Some other causes, definitely AFib, you know, where the atria are quivering, the blood pools in there, it doesn't perfuse correctly out into circulation in the body. Very known cause, and there are some others. So atherosclerotic plaque is one, bacterial endocarditis, recent myocardial infarctions, MIs, rheumatic heart disease, and a ventricular aneurysm could also be a cause of this. This type of stroke has a sudden onset and immediate deficit. So here's something that's a little bit different. So, you know, maybe I could help you make a chart of this and how they're all similar and what makes them all different. It'll be quick because remember, it's hitting that block. Everything was fine, and then all of a sudden a clot stuck somewhere, and they are immediate deficits. You may see manifestations, and the last hours or days, they can persist. They may disappear. What happens if the clot breaks up a little bit or moves and perfusion starts getting restored? But here's where we get to a really bad place. What if the manifestations don't go away? What if the clot stays there? And what if it gets even worse? So hemorrhagic. This is the what if it gets even worse. So this is a rupture of a cerebral blood vessel. This occurs when there's sustained increase in the systolic and diastolic blood pressures. So when you're thinking about that, you know, just think we have hypertension that's uncontrolled, or maybe there's a clot that's putting more pressure on there. Those are the things that can cause this increase in pressure. It's going to end up having a cascade effect. Blood's going to enter, it's going to get blocked, there's these pressures there, it's going to compress the tissues. Vasospasms can occur, leading to cerebral edema. That causes an inflammatory reaction in the body, and then subsequently impaired absorption and circulation of cerebral spinal fluid. These can occur suddenly, and again, often when a person is active. Now, there's two different subtypes, so to speak, and that's intracerebral, and that's bleeding within the brain, and there's subarachnoid, and that is bleeding into the spaces around the brain. All of this is very, very bad. It is very sudden. There are certain nursing interventions that you need to be mindful of and do in an immediate fashion for this type of brain attack. So to just kind of keep staying on here for a little bit, it does occur suddenly while engaged in activity. So again, you want to think about why. Well, if there's this vessel that has all this pressure and we're having this activity, blood pressure rises, or there's sustained blood pressure, that's going to cause the vessels to stretch and to weaken. And then they could eventually break and bleed. Again, hypertension is the most common cause. And this, when you have high blood pressure, you guys know this, it just puts so much demand on those vessels in the body. And people this is why hypertension is a silent killer. Like, we can live with it. But after a while, after years and years and years, as our blood pressure goes up and our vessels weaken, we're just not able to maintain that elasticity anymore. There are some other causes. And these can be caused, hemorrhagic strokes can be caused by trauma, erosion of the blood vessels by tumors, anticoagulant therapy, and certain blood disorders. This does have the poorest outcome, this type of brain attack. It is a rapid onset. As nurses, we need to know that this also is dependent on the location of the hemorrhage, and we need to watch for a client that has a severe or sudden onset of headache, vomiting, hemiplegia, loss of consciousness, increased intracranial pressure. This can lead to coma and subsequently death. So looking at risk factors, remember, if we can prevent a brain attack or a stroke, that is best. Prevention is always key. And in order to do that, we need to know the risk factors. We've already talked about hypertension. Heart disease comes in line. Diabetes is a risk factor for almost everything. Sleep apnea, hyperlipidemia, of course. Smoking. Now, we always never smoke, tell clients to stop, but there's a gender link to this. So I want you to think about this, and I'll give you the gender. Female smokers, females of a childbearing age. What is the connection there? If anybody has that answer, post it in the quiz 4 questions forum I created, the discussion forum, and I'd love to talk some more about that. Sickle cell, substance abuse. The stroke belt is interesting. There is an area, a region of the United States that has a higher incidence of stroke. So they call that the stroke belt. And that is the southeastern United States. That is us, ladies and gentlemen. Of course, a family history or prior history of those mini strokes or any other stroke in the family. Gender, again, we did talk about gender. Women particularly, they have some certain things that can affect them. And then ethnicity. So I want you, and we always have to think of the ethnic diversity that we have. So ask yourself this: what ethnic populations would have a higher risk of developing a stroke, and why? So when we're considering manifestations and potential complications, again, manifestations are going to vary according to the artery involved and the area of the brain that's affected. Interestingly enough, women, our gender is such an outlier, we are more likely to report non-traditional manifestations. and I don't know, we do that with a lot of heart attacks too. We have non-traditional manifestations, but for strokes and brain attacks, we might say disorientation, confusion, or a little bit of consciousness change. Strokes are usually sudden, focal, and one-sided. Most commonly, what you'll see is weakness of the face and arm and sometimes the leg. Some other things that you may see in manifestations of your clients: numbness on one side, vision impairment or loss of vision, definitely speech difficulties, sudden severe headache. Think when you see sudden severe headache, nausea, vomiting, think hemorrhagic stroke, difficulties with balance. Now, there is a whole host of complications that come with a client that's had a brain attack, and we are going to talk about each and every one of these on the next couple of slides. So with regard to sensory and perceptual complications, ultimately this is going to alter the ability of the client to integrate, interpret, and attend to sensory or sensor data. This can affect vision, hearing, equilibrium, taste, sense of smell, and perceptions of all the things listed there on the slide. So when you see this, again, this should be drawing you to thinking of a nursing diagnosis, risk for injury. I want you to think safety, and then I want you to think, hopefully you're screaming it out loud. You should be thinking Maslow. We need to think about that when we're providing care. So here's some key terms specific for sensory and perceptual. So I hope you did get a chance to work out the key terms worksheet that I provided. Again, if you don't know what a word means, it's really hard to provide care to the client or recognize exactly what something is. And it is challenging to answer a question, an NCLEX style question, when they use these terms and are unsure. So Hemaniopia, and I'm probably obliterating the way I say it. This is basically a visual disturbance or blindness in the visual field, over half of it. Now, hominis, remember that's the same. You're going to see that on both sides of the eye, so it'll affect both of them. Agnosia, this is the inability to interpret sensation and recognize things, and you may remember that from talking about Alzheimer's. Apraxia, the client's not going to be able to perform purposeful motor actions. Also neglect syndrome. It's also known as unilateral neglect. It's most common in the right hemisphere strokes. And then there is pain and discomfort, and this can be acute, numbness, having strange sensations. Think about this when we're talking about pain and the ability to sense, lots of things: hot and cold, burning pain, tingling, stabbing, sharp, all of those descriptors. It most happens in the extremities. It can worsen with movement and temperature changes, and interestingly, it will not be relieved by pain medication or other treatments. So one of the most challenging complications probably to deal with as nurses or as family and caretakers is cognitive and behavioral, because this is going to alter everything. Clients may have memory loss, decreased attention span, so that's going to cause challenges with patient education or a client doing certain things. Poor judgment. Okay, this is all affecting their brain. There's decreased perfusion, decreased oxygenation, cell death. So what they would normally had judgment on and done appropriately, they will now tend to manifest inappropriate judgment. They lose the ability to think abstractly. So that takes them, if you're thinking levels of development, stages of development, younger children are more concrete. It's black and white. If you lose your ability to think abstractly, you lose that thinking in like the bigger box and bigger picture. Behavioral changes could vary. Anger, aggression, sadness, crying, and laughing. And these are not at any control of the patient. They just happen. So it's not anything that brings it on. Loss of self-control, same thing, and decreased tolerance to stress or stressors. So tying right into that is complications of communication. If you've cared for a client with brain attack, you may know that their ability to communicate is impaired. And again, it's going to involve language, speech, memory, reasoning, and emotion. They all play together in the sandbox. But mostly it's language, either vocal or written. So again, going back to those key terms, we need to know what aphasia is. And there's 3 different types, and you need to know the difference between the type because these clients can manifest in varying ways. So the first one we have is expressive. And this is where a client's comprehension is intact. They have the ability to comprehend maybe what you're saying or writing to them. However, they don't have the ability to express it vocally or written. So what you might hear from a patient are some words that make sense, like if you ask them a question, tell me what you ate for breakfast this morning, and you might hear eggs, bicycle, breakfast. They can comprehend what you're wanting, but it doesn't play that way, or it might be garbled. Okay. It's going to make some sense, but the client's going to need some help communicating, okay, because they're understanding. So ways we can do this is picture boards. So they, maybe they can point to a picture and get the answer to you that you need. Receptive. This is different. This is kind of the opposite. This is where the client is not comprehending, okay? Their speech, memory are effective. So they're not understanding what you're asking. So what now is coming back verbally or maybe written or drawing is incomprehensible and makes no sense. So you may ask them again, what did you eat for breakfast? And they don't understand, and they're like picking up their cell phone. They're saying goobly-gook. It makes no sense in relationship to what you're trying to communicate with them. And then finally, you can have a mix of both. So when you think about the communication aspect, again, this is all going to go back to the type of stroke, location of the brain, the severity, how long this has been going on. You really need to think about ways to communicate with your patient and understand the differences between them. So motor complications, these can range from mild weakness to severe limitations of movement. And it can be weakness, paralysis, spasticity. Key terms again, got to know what those are. Hemiplegia, so we're thinking about paralysis. That's one side of the body. Remember, clients are going to have that contralateral deficit. Hemiparesis would be weakness. Flaccidity, oh Lord, I'm not even going to do it, and spasticity. So basically what can happen is movement is flaccid, and then it can be spastic, and this can happen over time, approximately 1 to 2 months. So just to follow up a little bit more on that spasticity, that's going to affect the body positions when we're thinking about motor complications, and that could be pronation of the forearm, foot drop, rotation of the leg. So when we're thinking about in practice, we need to always think about, what kind of evidence do we see, what's the cause, and what's our nursing diagnosis. That's going to drive a plan of care. So I'd love you to pause the video right now, and based on this slide, these are the manifestations you would see in your client. So that's your evidence. I've already filled in the last block for you. Fill in the rest, and I want you to think about what you would do as a nurse, and I want you to focus on safety, because when we have motor deficits, motor complication, this is going to lead to altered mobility. It's going to further impair body function, and now we're going to have a whole host of complications, but I'd like you to come up with some nursing diagnostic statement and nursing interventions that focus on safety and really bring home Maslow's hierarchy of needs. So we really need to think about that altered mobility some more. It's not just one major area with clients with brain attack, but it is a very important area. Impaired and altered mobility can hinder the rest of the body system. So let's just take a few off this list. I want you to look at all of them. I want you to answer why to all of them, but think about it. Orthostatic hypotension. Well, what in the world does altered mobility have to do that, and why? Okay, so just think about it. If I'm not mobile, I can't move, can't get that blood pressure up, can't keep my body going. I'm laying in bed, I can't move, maybe can't even roll side to side. Then we have that orthostatic hypotension. Why increase thrombus formation? I hope you're staying in that same line of thought. Decrease activity, decrease mobility, not moving up and around, poor perfusion has a tendency to build up clots. And you can go down the list with this, but these are some really important complications that can result after, and while the client's trying to recover from stroke. So when we're looking at complications with elimination, this is going to deal with the bladder and the bowel. You may see infrequent, urgent urinary patterns, incontinence, bowel changes, of course, constipation. And this is all related to the cognitive deficits, immobility, and potential dehydration that's related to nutrition. So let's talk about collaboration. So this is super, super important. We always want to collaborate with our health care team. And there's some stages, and what we do as collaborative healthcare members is going to be dependent on which stage. So the first stage is prevention. Let's teach the client how to prevent a brain attack or mini stroke or anything. When they're in the acute stage, this is immediately after the stroke. And then there's the rehabilitative stage. This is after maybe the emergent condition is done, and now the client is trying to rehabilitate back to the best possible level of functioning that they can. We're focusing mainly on the acute stage. And this is going to deal with what you do there is diagnose the type and the cause. And that's going to, again, be based on the location and manifestations that you see. We need to make sure that we maintain cerebral perfusion. So I want to pause here and talk about that. We all know that high blood pressure is a no-no. Okay, nobody wants a blood pressure of like 230 over 110. Okay, that's just bad because that could lead to a stroke. You need to be mindful that when you're trying to treat clients that have had a brain attack, especially if there is a clot, we still need to be able to try and perfuse. So you do not want to, you want to maintain perfusion. You do want to decrease blood pressure so it's not horrible, but we do need to sometimes keep it a little bit elevated so we can keep perfusing. And then also in the acute stage, we want to prevent further deficits from happening. And if we maintain that perfusion, that's going to help prevent further deficits. So if you're kind of looking at the graphic on the right-hand side, this is something you're going to want to commit to memory, and it's a great way to teach clients what to do if they're having manifestations of stroke. And again, if you see that, you're probably going to see, you got to recognize those. And what you may see is F, facial drooping. A, arm weakness or paralysis. S, speech slurred or difficulties. And time. Remember, time is neurons. So the minute you see something, that is not the time to drive yourself to the hospital. That is not the time to do anything. You call 911 and you let them know, tell your clients, you let them know that's what's happening so that they can prepare. So again, teach your patients if they see anything like sudden weakness, numbness in the face, arm or leg, confusion, difficulty speaking, understanding speech, difficulty with vision, any severe headache with no cause, that is time to immediately call 911. So goals of stroke care, this is super important, and this is also a time when I teach this in class, I pause and we watch a video. So I'm going to try to get that Z-Dog video for you in your course because I really want you to watch it, because anything put to music sometimes helps me remember. But when we're thinking goals, rapid recognition and reaction to warning signs. Now this is nurses in the hospital teaching your patients at home. That's the first key. If clients are at home, we want rapid EMS dispatch. So that means call 911. If we're in the hospital, we need to be calling a rapid response, okay? Um, Rapid EMS transport with pre-notification. So if a client is calling 911, they need to verbalize, they need to know the symptoms and say that, because that EMS dispatch could then automatically transport to an agency that is stroke certified and has a team waiting. And the pre-notification piece will play into that, because there's going to be some things that as nurses that we are going to do that are super time sensitive, and they need to be done by certified people. Also, again, rapid diagnosis and treatment, especially in the hospital. That's why your assessments and the interventions that you do and the warnings and the rapid responses that you call will be paramount. So labs and diagnostics, also one of my favorite areas next to pharmacology that we're about to talk about. But for labs, okay, I, I never say memorize anything, because you can't memorize everything in nursing school, but there are a few things that I do say memorize, and that is your lab values. Okay, if you don't know the normal ranges and you don't know what to expect with a condition or exemplar, whether it's going to be high or low, you don't know what to do with that information. So when we're thinking about some primary labs, coagulation studies, these are your things like a PTT, and we need to know that, because especially if our client's going to be on heparin, okay, we have to know what that level's doing and what to anticipate. Do we anticipate, is it normal when we start the heparin? Do we anticipate it to go up or go down? A complete blood count, always warranted. A basic metabolic panel, renal panel, those are also warranted. Again, you need to know what you're looking for and what's normal. A few diagnostics that need to be done, and it's part of the critical piece of assessment. An NIH stroke scale, and this is going to assess level of consciousness, vision, facial paralysis, motor abilities, ataxia, sensation, language, and attention. So this stroke scale that you would do if I've used a clinic on a stroke floor. They had to do this for every patient that was coming in, and it is a whole host of questions, but it's going to determine all of that, because again, we're trying to find out where in the brain the stroke happened and how severe it is. A CT, absolutely warranted, especially if we're having you got to rule out whether it's hemorrhagic or it's ischemic. Okay, so a CT can help identify, is there a clot or is there a bleed? And if there's a bleed, that is very, very bad. We also may want to do a lumbar puncture, so we can look at the cerebral spinal fluid. All right, so when we're thinking about pharmacology, we need to go back to those stages. If a client has had maybe a mini stroke or a TIA, especially then we're thinking about prevention, because remember, those can cause an actual ischemic stroke to happen. So it wouldn't be uncommon for a client to be on antiplatelet agents like aspirin, okay, like Plavix. Those are things that are antiplatelets. Now, if a client is in an acute stage, which means they're actively having a stroke and we're trying to help them, we need to think about, one, what can we never give? Why don't we want to give anticoagulants or fibrinolytics with a certain type of stroke? And let me help you, that is that hemorrhagic. If they are already bleeding, we don't want to cause more harm. Warfarin may be given. Xarelto is common now. Heparin. Now I put this one in green because I do want you to look it up and I want you to know about it. If a client is having a stroke and they're in the hospital, it is not uncommon that they may be ordered a heparin drip. Now, the basics of what you need to know is, what does this medication do? Why are we giving it to the patient? What lab values do we expect? And if in the event things are abnormal due to the heparin, what is the reversal agent that you want to give and why? Okay. And Lovenox, not uncommon. Clients may get to a point where they come off the heparin. Maybe they're transitioning them to Coumadin. But in the interim too, they may also have Lovenox, and they may even go home with Lovenox. So I think you're familiar with that medication, but always know that with Lovenox, it's subcutaneous. You want to make sure you teach your patient correctly how to self-administer if they need to. Now, fibrinolytics, those are therapies used. They are going to help with the stroke and the clots, okay? They are actually going to break up, okay? So anticoagulants are going to help prevent a clot from forming. Fibrinolytics are actually going to bust it up, in lack of a better word. So a very common one is TPA or RTPA, and this is the gold standard for an ischemic stroke. Okay, so when I say what are contradictions, hemorrhagic stroke, you do not give this. That is why you need to do the CT and find out what kind of stroke it is, and you need to look at those manifestations, because you do not want to give this medication and this treatment to a client that is bleeding with a hemorrhagic stroke. It is most effective when given IV within 3 hours of onset of manifestation, and that's pretty much in the literature. So that's why time of start of symptoms is so imperative when it comes to brain attack. Because if they were at home and it took 30 minutes to get to the hospital, and then maybe they had to transfer to another hospital, if it's been longer than 3 hours, you cannot give this, okay? I think that's the basics of it. So take a look at those really dark, you should know those, heparin sodium and TPA. You also should be familiar with the others that are on the screen as well, but if we're thinking specifically brain attacks, those are the two I'd like you to focus for this segment. So just a few other classes to kind of tie in. Antihypertensives, if a client has hypertension, or if in the interim their blood pressure is elevated, those will come on board. Some literature says it's controversial. Steroids, again, remember, we have this reaction that's going to happen, and edema that's going to happen. So steroids wouldn't be uncommon to reduce cerebral edema. Results may not always be positive. Hyperosmotic solutions, diuretics if there's edema and swelling, especially of the lower extremities if it starts to affect the lungs, possibly anticonvulsants as the brain, if there's a bleed or if there's a stroke and there's pressure in the brain, it can start triggering seizure activity, so it wouldn't be uncommon to see maybe a protocol or orders for anticonvulsants. So maybe after the client gets discharged to a skilled facility, maybe home, there's going to be a lot of rehabilitation to bring them back to a level of functioning so they can do ADLs. And this is when everybody comes on board. And they're on board in the hospital too, but don't ever forget about physical therapy, you know, and help with that complications of mobility, occupational therapy, also speech, language, get them on board as well, especially in hospitals, so we can look at a client's ability to swallow, whether they're ready for a diet, things of that nature. All right, so let's really get into some pieces of what we need to do as nurses. Assessment is key, both the health history and the physical assessment. So it's complex and multi-dimensional. Remember, think back at all of the complications and all the things that we talked about. We want to eventually promote achievement for the clients to their maximum potential and quality of life. But we need to assess and identify needs of that individual and also the family. You know, when we're doing assessments, when we're thinking of things that we need to look at, of course, we need to look at visible signs. Again, think fast. Paralysis, facial drooping, difficulty speaking. We also need to know the risk factors, so we have to ask about that. Do you have hypertension or anything, diabetes that can lend itself? Are you a smoker? Are you female on contraceptives and smoke? Any history? Have you had a mini stroke? Anybody in your family have a stroke? Drug use, smoking, of course, always and forever. And then when did these signs and symptoms start? How severe are they? Any level of consciousness change? And then also we need to kind of tie in a little bit when we're thinking about just the patient interview is the family support systems. And remember, we're always thinking discharge begins on admission, so we're thinking forward. Physical assessment wise, always assess level of consciousness and their ability to communicate. You're going to need to do a full head to toe assessment because this is going to affect everything. Motor strength of the extremities, how they're coordinated. Ask them questions to see if they are having expressive aphasia. Do the stroke scale, always take the vital signs. Remember, we want to keep perfusion going, especially in an ischemic stroke. So do not be shocked by high blood pressure, but we do need to follow the protocol and provider's orders, and always look at their mobility status. So then you have all this data. And then now we need to think about, well, what kind of diagnoses or nursing diagnoses statements. So I want you to pause the video here for just a minute. And then I want you to think about what are some priorities that you would like to focus on. All right, so I hope you paused and came up with a few. Just think about this for nursing diagnoses and priority-wise. Risk for or ineffective tissue perfusion. Is that not what we're talking about today? So we want to fix that because that's what we want to do. Impaired physical mobility, and that can run the gamut of a lot of things, and that's going to lead us to a lot of safety interventions that we need to do and a lot of care for our clients. Impaired verbal communication. Remember, I said it's very challenging for clients to communicate, and it could be different for each patient. Also, impaired swallowing. I really want you to be mindful, and I really want you to go and look at what are the nursing interventions we need to do for a client that has impaired swallowing ability, because that is key. You need to remember these clients are going to come in, even if you're ruling out a TIA or a stroke, that you don't want them to have anything to eat or drink until an appropriate swallow screen has been done and they have been evaluated on their ability, because we do not want them to aspirate. And then if they aspirate, we do not want them to get pneumonia, because that can complicate the plan of care. So when we are in the planning phase of the nursing process, this is where we are developing goals or outcomes for our clients. And remember, goals are overarching. So some things that we want to do when we're thinking about maybe some of those priority things that I just talked about with the nursing diagnosis. Maintain blood pressure within prescribed limits. So again, you have to look at the type of brain attack that's happening. You have to follow the prescriber's orders, but you do need to be knowledgeable of that. We need to ambulate, increase activity as tolerated. Now, this may be going more into the rehabilitative phase. At first, we're just going to have to mitigate what we're doing in that moment in time. For example, in the hospital, it's going to take time for them to come back to activities as tolerated. So they are going to need assistance with eating, with drinking if they're allowed, brushing their teeth, using the bathroom, all of those things. And you have to keep in mind the other complications. For example, visual disturbances and visual field disturbances. That could make a big difference in a client's safety or their ability to eat. And we want our clients as a goal to participate in therapies that maximize their communication technique. So that's why we need speech on board, and that's why we need help, because it's going to take a while for clients to learn how to communicate until the deficits start to resolve. All right, so this is the implementation part of the nursing process. And nurses, this is your world. Okay, this is what you are going to do. So let's talk about some of these categories and some of the nursing interventions, and there are more. So I would like you to create your own list in addition to the few that I speak of. Maintaining cerebral perfusion and that blood pressure. Well, what do we want to do? We want to make sure that, again, we keep the blood pressure in the order of the parameters based on the client's need. When we're thinking about cerebral perfusion, we think about oxygenation. So we want to monitor respiratory status and airway patency. Always have suction available in case your client has difficulty swallowing their own saliva. Clients may be placed on a sideline position. We need to have oxygen as needed, and always monitor for changes of level of consciousness, because changes in LOC, one of the first signs indicative of increasing intracranial pressure. Let's see, for promoting physical mobility, passive range of motion or active range of motion to the unaffected, let me back up. Passive range of motion to the affected side and active range of motion to the unaffected side. When we're thinking about promoting self-care, we want to encourage the client to use the unaffected side for self-care. We want to teach the patient to address the affected side first. And we always want to collaborate with OT and any PT and use of assistive devices because they will need those. When we are thinking verbal communication, you really want to, and this is hard because it can be really challenging to communicate with a client that's had a stroke. Always treat the patient as an adult. Please do not make assumptions that they do not understand what you're saying, even though that could be the case. Don't always assume they have a hearing deficit, and don't yell or raise your voice, okay? Give your client time to respond and face the client directly and speak slowly. If you can't understand what the patient is saying, let them know that and be honest. When you're talking, use short, simple statements or questions and accept the client's frustration and anger. Remember, it's going to have behavioral changes as well. And try alternate methods of communication if verbal is not working, writing if it's applicable, a picture chart. For promoting urinary and bowel elimination, always use positive reinforcement and try not to get discouraged or let the client get discouraged when bowel patterns and urinary patterns have changed. Fluids if applicable, high fiber diet if that is allowed, physical activity in any way, shape, or form, and always continued assessment to make sure there's no problems stemming from impaired urinary or bowel activity. Safety, huge key right here. Dysphagia can cause choking, drooling, aspiration, or regurgitation. Again, you have to do a swallow study or swallow screen. When a client is eating, always put them in an upright position, okay? They need to have pureed or soft foods. Liquids should be thickened or the consistency of honey if the order allows. Remember, they stay NPO until it can be determined what they're able to do. You need to teach clients to eat and swallow again. This takes time and this is hard work. When they're eating or drinking, you should be there to assess whether they are coughing, because if they are, then that's indicative of aspiration. And again, always have suction at the bedside. You want to always monitor lung sounds. It's not uncommon as a client is eating, maybe they're taking a little break. Maybe you hear a cough, you pause, you assess, look at the oxygen saturation, listen to their lungs, see if you hear anything. Minimize their distractions. Again, eating is very hard work, especially when you have to relearn how to chew and how to swallow. So minimize the distractions, people coming into the room, communications going on at the same time because we don't want to talk and eat, the TV, anything like that. So they can focus on eating or swallowing. And then you may have to give step-by-step instructions when they're eating or how to eat, and you may have to do this multiple times. And finally, we've come to evaluation or evaluate in the nursing process. We want to know, can the client participate in therapy, communicate effectively? Is the family involved in the plan of care? Have we eliminated complications or tried to improve function? Ultimately, frequent evaluation is extremely important because evaluation and reassessment go hand in hand, and that drives our changes in the plan of care. And with every change in the patient status, nursing care plan will need to be revised. What you do will need to be revised, and this is ongoing. Hey, you stuck with me to the end, about almost an hour, a little bit lengthy on this one compared to some of my others. So I really want you to take the time and review. And if you have any questions about this presentation or the content, you can post them in your discussion forum area of your Blackboard course in the questions for quiz 4 discussion forum. Thank you and have a wonderful day.